sure if it ever gets comfortable listening about yourself and big audience. Thank you for the warm introduction. Thank you everybody for being here today. This is a somber topic, but an important topic. So hopefully I will not depress you too much and leave you more energized to do the work that we've all set out to do. Just a quick show of hands. Who here is in some way helping people with suicidal thoughts in any helping role? Great, so the vast majority. And people in peer roles, survivors, and family members? Great, oh good. So we really have quite an eclectic group. Okay, so thank you everybody for being here. Let's get started. I will try not to yak at you for the whole time. I think the Q&A is the most important aspect of this. If I can get my slides going, that is. This is the one I should do. Great, okay. All right, so just a quick to show you, this is my sources of income, so I'm not promoting or pushing any commercial product. Okay. What we'll focus on today is the impact of suicide on young people. I suspect you know much of this information, but it sets the context for why the work is so important. Also want to briefly talk about the zero suicide model, and then how we are using our experience zero suicide model to improve care for students at USC. So, all right, so this is the depressing part, but this is why we're all here. Right? The impact of suicide. Does anybody know what these numbers reflect, other than the title of the slide? Anyone? So sadly, 48,183 is the number of people we lost to suicide in 2021. Even more sadly, the CDC's tentative numbers for 2022 are even higher. They're almost 50,000 people that we lost. And as you might all suspect, it's probably not capturing all deaths by suicide. So the problem is huge, and unfortunately it is growing. The 4,148 is the number of Californians we lost to suicide in 2021 as well. So that's magnitude of the problem. If those numbers seem big, then consider that 12 million people thought about suicide in the United States. And that is just astronomical. 3.5 million people made suicide plans. 1.7 million people made an attempt to take their lives. In that context, 48,000 seems so difficult to know, to find people who are going to die by suicide in the context of how big the numbers of people thinking about suicide are. Many of you know this, but this is the challenge we have before us, is identifying people. We can only start with people who have suicidal thoughts and then follow them and work with them to prevent the death. But the magnitude of the problem is way, way bigger than 48,000 people who we've lost. These are national and California numbers of people died by suicide as a percentage of per 100,000 people, per 100,000 population. The gray line is the national data. So as you can tell, in the last decade, we saw a slight dip during COVID, but nationally the numbers have gone right back up since the pandemic settled a little bit. In California, thankfully, the numbers have not gone back up to pre-pandemic numbers, and it'd be very interesting to know why that is helping. I'm also happy to share these slides with you, and the sources of the information are on the slides at the bottom of the slide. moving forward. Let's see. Should I just move it from there?
I don't know.
It's on the laptop.
I'm not sure.
No.
Oh, but it's not. There.
Oh, here we go. Just a little bit. Okay. And then more pertinent to the topic and just as serious is suicide is the #2 leading cause of death among young people, among adolescents and young adults, but also true for college students. In 2021, we lost 1,100 students to suicide. So just the same level of tragedy. And the next two elements of data that I'm sharing, I think, have even more pertinence is 25% of college students know someone who has died by suicide. That is way too young an age to become familiar with death, let alone death by suicide. And 40%, almost half of every college student knows somebody who had attempted suicide. That's the size of the problem that we are dealing with. So again, sorry to start on such a somber note. You can't not start on such a somber note, but the main emphasis is going to be what can we do about this? So what's available at USC is, I do think, far above what most universities provide for their students. I won't go into a whole lot of detail, but just to give you a framework with what was already existing that we are looking to build on. Counseling and Mental Health Services is a 90-faculty division of the Department of Psychiatry that has therapists, psychologists, psychiatrists who will see patients on a very quick turnaround. They will assess patients, triage them, and connect them with treatment. There's MHEART, which is a relatively new program, which is non-police force, so social workers and other folks helping police or Department of Public Safety respond to emergencies. So it's a kinder, gentler way of approaching mental health crises. I'm sure I don't need to tell you how people with mental health emergencies are treated largely in the community. So this is a way to approaching public safety with a heart. RSVP is resources for students to help prevent, but also deal with the impact of sexual trauma on campus. Religious and spiritual counseling. And last, but certainly not the least, and closest to my heart and where I am, is PBHS, Psychiatry and Behavioral Health Services, which is on-campus longer-term care. So counseling and mental health services, which, as most universities do, are able to screen, assess, and then triage to longer-term care. At USC, we've built this entire treatment program that students have access to. And so the Engman building that you see on the right, the 3rd floor is counseling and mental health, 5th floor is PBHS. So students only need to go 2 floors above to get care on a more comprehensive basis for longer term. We also have a really innovative program to screen and identify mental health problems proactively for all USC students. So this is called My Mental Health. It's also a unique program to USC and potentially has a huge impact. And so instead of waiting for people to be in crises, every student who enters USC will get this survey that identifies what mental health problems they may be struggling with, starting from any mental health concern all the way up to suicidal thoughts and and then we connect them with services on a proactive basis as opposed to waiting for a crisis. Just quickly, this program was launched 2 years ago. Last year was the first full year that the program was available. Survey sent out to 13,500 students. That number will double in this academic year. 2,100 students completed it. And as you can see, the responses were ranked as acute risk, low risk, high risk, moderate risk, and mild risk. And as you might expect, the numbers come in that way. But I'm very happy to report to you that 100% of students who identified moderate or high risk had outreach, were connected, and were offered services right away. And with an engagement level of 55%. So that's quite impressive. So it's a very unique and proactive approach that it's very hard to do in the community in general, but in our student campus, we're really happy to be doing this. Are you all familiar with zero suicide, or any of you with that model? Okay, I'm a big fan, so I would really suggest if you have the time, go to zerosuicide.org. What it does is it will save you tons and tons of time in finding all the resources you need to transform your organization. They have a zero suicide model, and you can assess where your organization is compared to where what the best practices are, and all the resources in terms of published studies, best practices, tools for risk assessment, screening, all of that is available. Tons and tons and tons of resources. It's a very helpful website. And they are essentially working on the principle of suicide is preventable. And I think that is a really important concept for us. I can't tell you how many times the magnitude of the problem can bring us down. It really feels too monumental to address. I find it incredibly inspiring to say our goal is zero suicide. It's challenging, it's difficult. I'm not wearing rose-colored glasses that this is going to happen tomorrow, but that this must be our goal is very clear. And I find it incredibly inspirational that we have an organization that supports this exact goal. And what their work is to do system-wide transformation to achieve reductions in zero suicide. And we don't have time to go over this, but just wanted to give you the sort of general framework. They have 7 steps. You'll probably recognize these as organizational change management. So in the general framework, it's a familiar, but when you get into the details, where it really helps for you to think about how your organization can adopt these changes. And I'll give you an example of USC, so instead of going over the theoretical model. This is also only for reference. They really have made a big impact. Organizations that have adopted zero suicide have seen substantial results. The framework also started from the Henry Ford Health System, and in their health system for a couple of years, they actually did achieve zero suicide. It was hard to sustain, as you might imagine, but many other organizations have done that and achieved really impressive results. Right, so mostly I want to focus on what's happening at USC because we could talk about any of those topics all day long. So what we did at USC, or not did, I should say, what we are doing, because very much in the present and in the future, is we had students die by suicide in the last academic year. We did what's called root cause analyses. Are you all familiar with that? And just as it sounds, it's basically doing a deep dive into understanding what happened at every level, in a non-blame environment. Let's figure out what happened with the benefit of hindsight. What could we have done? What were the contributory factors? And what can we change for the future? So it's a very heart-wrenching, honest conversation that we have to have. It is protected as in quality improvement. It's not discoverable. So you can be completely honest and have the discussion like, if I only knew, I would have done this. So you can really have that very open conversation in a very small group. And this is part where most people don't talk about these things, but I don't think we change the outcome of suicide unless we start talking about. So I'm not going to talk about the findings of the root cause analysis. I think it's important to protect the confidentiality of people who gave out the information, but I will be sharing the changes we are going to make as a result of learning from those. We also spent a lot of time talking with clinicians as well as survivors of serious suicide attempts, and to the extent allowed by family members and even roommates of those who survived suicide. And then we also use the zero suicide model. So what you're going to hear is a combination of the things that came from this effort. Root cause analysis itself, what we found is our counseling and mental health service has one electronic health record. And as you know, in healthcare, we live in these electronic health records. Everything we see, we do is documented in these things. There is one health record for counseling and mental health, and the rest of CAC uses another. And so it's Cerner and point and click. So as you can tell, that can cause communication problems and lack of timely information. As much as we were identifying patients at high risk, we didn't have clear definitions. So when things get really, really hectic and busy in the middle of the semester, therapists identified a hesitation to add people to the high risk list because it already felt so overwhelming and they didn't want to take up more time. And so we wanted to support them in having standardized way of identifying high risk as opposed to them feeling like they're imposing on others. Means restriction, if you've thought about suicide, you've probably thought about means restriction. This is super important and has to be very local to the problems that you're facing. So I'll talk a little bit about that. We also found patients who our standard treatments were not helping them enough. So thinking about what else we can offer to help improve that care. Major challenge that we continue to face is when students are off campus. So they leave for winter break for close to a month, summer break is even longer. If they are out of state or out of country, we're not allowed to treat them. All of us are licensed in California, some of us are licensed in other states, but other states will not allow us to treat a student, the same student we've been working with the whole time, as soon as they cross state boundaries. And of course, we also have a lot of international students, and we are not able to treat them. So that continuity of care is a massive problem. And we've also found that stigma and distrust of healthcare systems played an important role in the death. And honestly, this I find the most vexing in terms of how to make improvements. It will take a lot of effort, a lot of time, but this is very real. I know from who I've talked to already and people who are exhibiting outside that this is a concept well understood by all of you. So what we did as a result of the root cause analysis is we created a suicide prevention work group. We combined faculty from student health, which is primary care, from counseling and mental health services, from CSI, which is the crisis intervention, as well as PBHS. So we all sat down together and said, what can we do? Every place that had seen a student die by suicide did their own root cause analyses. We brought those results in. We brought the clinicians in who had been working with the students who died by suicide. We got feedback from others volunteered. And all of that was taken into creating this work group, as well as a deep dive into the zero suicide model. From that came better ways of standardizing suicide risk assessment, screening, and having the same understanding. So we were all doing suicide screening, but everybody was using a different tool. So the language was a little bit different. So we found a student identified as moderate risk in one area, but high risk in another area, simply because of different definitions. And then as a result, different follow-up happened. So we are now going to use the Columbia Suicide Screening Severity Scale, CSSRS. It is a mouthful. And we're going to use that in all of the USC student care environments. And then we will use the CSSRS, but also then superimpose other criteria, which I'll share with you in just a moment, to do risk identification. So if we can identify, CSSRS says moderate risk, but they have tons of protective factors, that may actually lower the risk. Or identifies as moderate risk, but there are very recent stressors or anticipated stressors that the CSSRS might not ask for, which might raise it. So we have the ability to be flexible, but there is a standardized platform to begin with. And then when the risk stratification happens, a guideline for students and for our faculty, what kind of care they're going to get. So I'll show you a little bit of that. Engagement of case management, the intensity of that as the risk is different, allowing for the treatment teams taking care of the highest risk to have time to meet with and consult with colleagues. And those of you who are in clinical practice, sometimes you don't get a lot of thinking time. You're seeing one patient and you move to the other patient, they have different concerns and you move on and on and on. And you don't get to really sit back and say, what could I do differently with this patient? Let me think this through. Can I consult with my colleague or my supervisor? So we're building in that time for the high-risk patients. And also, no-shows might get, if you're low risk, you might get a reminder by text or a message. But if you're high risk, you're going to get calls. And we'll try and reach you a couple of different ways. So those that's what I mean. I'm not listing every single intervention, but just a flavor of what that means when we do risk stratification. This slide is not meant for you to read, but just to emphasize what the different categories are. So if you're low risk, it means that. Intermediate risk, this is what we'll do. High risk. Again, this is not meant to describe details, but just to say that thinking about, for us, when we have a high-risk student, what should that mean? How does the care step up from somebody who's identified as moderate risk? What are we going to be doing? And then the acute risk. So it's really sitting down, building consensus, and having guidelines for everybody. So when we have a high-risk student, they must get this. And that's the emphasis rather than the details. So the details, I think, will have to be local to each facility. I was talking about treatment refractory illnesses. So things that we are building are, so now TMS, transcranial magnetic stimulation for depression treatment, but also for severe OCD is now available on student campus. It had been available at CAC main campus, but now also at student campus. Same for intranasal ketamine therapy. This is a very promising treatment for suicidality. After a long time, we've had treatments focused on suicidal thoughts themselves, and this is a very promising treatment. So not in place yet, but we're very close to having that available for students soon. ECT, again, this is not a new treatment, but by far the most effective treatment for depression, where therapy and medications have not helped, making our process smooth for students to be able to access it. This can only be provided in the hospital, so it's provided at main CAC hospital, but just making the process very smooth for students to be able to get that. Also partnerships with IOP programs, partial hospital programs, residential treatment programs, and hospitalizations. All of those is fostering those relationships, building them so that for the student, it's a seamless experience. Gaps in care. This is what I was referring to is when students leave town or country, it becomes very challenging. So we cannot provide any therapy or treatment to students because we'd be practicing in those states. So if one of us has a license in that state, we may temporarily take over the care of that student and still do telehealth visits, but we do have quite a diverse student body in terms of geographically where they come from. And so what we so far can do is intensify case management. So case management is not bound by state limits. We can do that. And what we are doing is proactively before the longer breaks, seeing who is on our high-risk list and proactively planning what their care would look like in another state. So contacting agencies there. As you might imagine, despite that proactive effort, it's not easy to find people care because it's often several weeks to months that people have to wait to even get involved and get therapy or a psychiatry appointment. So still very, very challenging. Means restriction. So what this has meant for us on a very concrete level is training in CALM, which is counseling on access to lethal means. Are you all familiar with CALM, this training? It is available free of cost. You can go to CALM's website. The Zero Suicide website also has a link to this training, and anyone can sign up for it. The backstory on this is also just as important. Is it started at Dartmouth with a wonderful person called Elaine Frank, who in a small town in New Hampshire, there were 2 deaths by suicide, both by gunshot, on the same weekend. I mean, it literally tore apart the entire town. Very tragic. And much like you might expect, there was a lot of finger pointing of this is a gun problem, this is a suicide problem, it's a mental health problem, and the national discourse as we see it and complete inaction. Instead of doing that, Elaine actually went to the gun shops and say, how can we partner with you to prevent suicides? And instead of the gun shop owners feeling defensive, could actually express that last thing they ever want to do is sell a gun to somebody who wants to use it to take their own lives. So she started what's since been called the Gun Shop Project. It started in a small town in New Hampshire, it expanded to New Hampshire. I was in Vermont at the time and worked with her very closely. And then later she developed this training to equip clinicians with talking about means. This is not a topic comfortable for us, for many of us. I hope it is for some of you or most of you, but it has not been something we're willing to talk to our patients. So I think having some training in how to talk about this. Nationally, more than 50% of the deaths by suicide are by gunshot. Thankfully, they are not in California, and thankfully that is not the leading cause of death at USC. But there are other means where means restriction and talking very directly, clearly, planning for it is very important. So what happens at USC is medication overdose and jumping from buildings. Those are the 2 most common methods. And so we need to be able to talk to students. We need to be able to talk with them about acquiring chemicals which are widely available on the internet and are lethal and are even hard to detect. So sometimes it's even hard to tell the cause of death because these are not chemicals, as in medications that would ordinarily be screened for. We're looking to put signage on rooftops to, indicate to people they can always get help, the numbers to contact, and how to reach emergency help, and also planning for developing safety nets from high places. We're taking a very careful approach to medication prescriptions when we identify that as a risk. So it would be based on the lethality of a certain medication. So we don't want everybody to have to go to the pharmacy every week to pick up 1 week's worth of medication, but if you happen to be on a medication that is high risk, then that may be the safest thing to do, and other medications can still be monthly if they are not dangerous. Safe storage and disposal, self-evident, I guess. Back to electronic health records. So telling you all about the 2 different electronic health records that we use, and they don't talk to each other. So we're having to work with our IT folks to develop patches as the temporary work. So as an example, I was telling you about the My Mental Health Initiative. So students would complete a survey, and students can and have indicated they are dealing with suicidal thoughts on those surveys, and so there is a response immediately. And sometimes students will say, oh, no, I didn't mean it, but we still want to keep the student engaged and see what's going on and meet with them. And so when they complete the My Mental Health survey, they would go to counseling and mental health services, and then once that triage happened, they're referred to psychiatry and behavioral health. All of the information at CMH isn't automatically available to PBHS therapists, including identified suicide risk on the My Mental Health survey. So they have access to it, but it's not automatically available in the environment that they're in. So everybody that can go into a separate EHR, but busy days, busy schedules, it's hard to go into other records and review all of that, and also review your own record. So the temporary solution is to create a patch to pass through certain documents that will automatically be pushed to the EHR. So whichever direction that may be, but that's going to be pushed as opposed to expecting clinicians to check 2 records. And then health information exchange will be the next step, is where the two records talk to each other. Strangely enough, I can see records from CVS, but I can't see records from 2 floors below. This topic, as many of you are familiar with, is very, very challenging. We've already had a conversation this morning about the impact of stigma against mental illness that keeps people from getting care in a timely way, distrust of mental health specifically, but also distrust of healthcare systems. So people have been traditionally abused, misused by the health system. They don't trust it. They have very good reasons not to trust it, and that trust takes a lot of time. And we found, at least in one situation, it was too late, literally a week too late to have them see a psychiatrist because they just did not trust the healthcare system and did not want to see anybody that wasn't in similar ethnic backgrounds. And that literally cost them their lives. So that's how serious this problem is. We are looking to do outreach, looking to partner with student organizations to build trust, education, let them know what it means when you come to get help. We're looking to start a podcast that sort of normalize this conversation about just what to expect when you call counseling and mental health. What happens? Many people associate mental health care with, if I disclose suicidal ideation, I'm going to be in a state hospital for the next 10 years. That is not an uncommon phenomenon. It's not the truth. It should never be the truth anymore, but it was the truth. It comes from reality, right? And so I think that building that trust, breaking down these barriers is going to take a lot of time and effort and come from multiple different angles. And so I think working with students in every which way that we can reach them and partnering them with who they prefer and trust and can open up to, which is so easy to say. In reality, it is so complex, right? Because as many of you know, recruitment's not easy. It's so hard to find people who are skilled at the work that they do, and it becomes even more challenging to match people with exactly who they prefer. So for example, our women therapists and psychiatrists are overwhelmed because so many of our students prefer meeting with women. And so it's noble, and we want to match them with who they prefer. We also have to take care of our faculty so they're not overwhelmed. So we're constantly looking to improve and hire based on the needs of our population. I mentioned most of these, but just in terms of quick summary of training. So CSSRS is the Columbia Suicide Screening Tool. We're so lucky that we partnered with Dr. Posner from Columbia, who developed the tool. She's already done 2 trainings for us, and we're happy to bring her back for more. And that is, her passion for suicide prevention is unmatchable. She is so energetic and infectious that she really gives you what you need to get going. CALM is what I just referred to. We're also training our teams in suicide care focused cognitive behavior therapy. We partnered with David Rudd. And again, this is getting away from, at least what my training was like, is suicide is a byproduct of other mental illnesses, like depression, like anxiety, like bipolar disorder, schizophrenia. Yes, there's very high correlation with them. What these new modalities are doing is seeing suicide as its own independent problem and focusing therapy on those thoughts, just as if they were anxiety thoughts, OCD thoughts, and focusing on, and these are showing much more promising results by having that direct conversation about suicide. And we've also partnered with TD Hurst, I believe they are here today, in training our non-clinical staff, and they just completed 2 rounds of training with SafeTalk. If they don't know it yet, we're going to be calling them to expand this training for other non-clinical staff. So I think it's a public health approach in that way. Everybody who you come in contact with should not be afraid to talk about suicide and connect you with the right resources. What can we do for our caregivers? We are developing a DBT support group. Suicide treatment, by far and away, DBT, thank you, is the most effective treatment that we know of in terms of therapy. We're building resources to support our clinicians who are providing this care, because it is obviously quite intense. And also creating a support program for those of our faculty who've lost students, or this would be anywhere in our department, so patients or students, to suicide and supporting them. I hope none of you have experienced this. If you have, then you know how gut-wrenching it is. You question everything about yourself. You go through every grief stage that one sees in other grieving processes. It's a very, very difficult time. So I think supporting our faculty through that and making sure that we continue this effort of getting better rather than losing heart. And creating a robust incident review process that has led us to coming up with these change processes. And so we have miles to go before we sleep. And just a quick methodology, if you are QI nerds, this is, and as I am, plan, do, study, act is the motto we live by. And so we plan this, we are in the middle of doing this, we will study the results of our actions, and we will act on those. So I'm going to leave you with two quotes that I find incredibly inspiring. Edward Deming, who's a healthcare quality guru, it's not enough to do your best. You must know what to do and then do your best. I think that captures the spirit of what we are looking to do at USC. We all come at it with our best intentions, but we need to continually equip ourselves with better and better knowledge, better action, and so we know what to do and then do our best. And I suspect this applies to many of you in this room, or you wouldn't be spending your weekend here. Thank you.
We're going to open this up. We have about 10 minutes of questions before we move on to our next speaker. And I think Dr. Feldman has a question to start us off.
Thank you, Dr. Batra. If you're coming from a place where you're saying that 100% of suicides are preventable, is that going to put a chilling effect on clinicians who won't want to see patients with any kind of suicidal ideation? Because if they ultimately die by suicide, someone's going to say, well, this was preventable.
Absolutely, and that is the most important question, and I have encountered this question from our faculty every place I've worked in. So what that is prefaced by is zero suicide doesn't mean anybody is going to be blamed for suicide. I'll be the first one to acknowledge we don't have the means to do this right now. But I also didn't want to hear John F. Kennedy say, we're going to go half the way to the moon. The goal was to get to the moon. The goal is for us to get to zero suicide. It doesn't mean I'm going to blame my way to get to zero suicide. It means that we're going to support you in doing everything we can to get to zero suicide and learn from every sad experience that we have to make ourselves better and better.
Yeah, just raise your hand and we'll come to you with a microphone so everyone can hear. Hello. Oh, I'm the guinea pig, sorry. I wanted to ask you, you said the program started 2 years ago on campus, that you started implementing. When the survey, I apologize.
The last year was the first year that it was given out.
So how is the campus addressing the need to have that survey go out to sophomores? Did the survey go only to freshmen, incoming freshmen?
Last year it did. So there is a sort of staging plan, and over 3 years it will go up to all students. This year it will go up to half the number of students because we're also looking to build up resources, right? What we didn't want to do is send out the survey to almost 50,000 students. They ask for help and we have no way of scaling up to that help. So I think this is happening in tandem.
Awesome. Yeah, just for the protection of the students that are struggling even through the pressure of the years ahead. So thank you so much.
Hello, thank you. Thank you so much for your talk. I have two quick questions. I wonder if you're thinking of combining psychiatry and talk therapy with the same caregiver, because I know that that can be very, very helpful.
We often do that. We do have a complement of therapists and all disciplines of therapists and psychiatrists. It is not unusual for our psychiatrists to also do therapy. It's a matter of utilizing people with the best expertise for the problem that the student presents. But by far and away, most of our students get both therapy and psychiatry, not always with the same person, but it is certainly possible to do that.
I know that my 30-something daughter has found it extremely helpful.
Great.
Because the meds and her emotions, they all work together with the same person.
Absolutely.
Also, as a suicide loss survivor and a specialist in working with suicide loss survivors, I wonder about the zero suicide, the emotional trauma of zero suicide on survivors. How you think that could be mitigated, and I wonder if there's another term you can use besides zero.
Say more about that. I'm not sure I understand.
Well, you're hoping for zero suicides, and I understand that it's really, is it possible? It's something, yes, we want to get all the way to the moon, and that took, of course, many decades, but we're talking about something very different here. We're talking about the physicality and the engineering of getting to the moon, but now when we're talking about suicide, we're talking about something entirely different. We're talking about emotions, we're talking about mental health, we're talking about sociology, and the way people have been raised and their family situations. There's so much involved in that. And is it really a usable term when we're dealing with suicide loss survivors, where they always will be there? And I know that as a suicide loss survivor, I just don't believe every suicide is preventable. I'm sorry if I offend anybody, but this is my belief. And as I work with so many people in crisis response and facilitating, we are hurting survivors by pushing this on them.
That is certainly the furthest from my intent. It is very controversial. I mean, I've spoken with Mike Hogan, who was one of the original people who started this National Action Alliance for Suicide Prevention. It is a divisive term. Some people find it inspirational, others find it to be an impossible task and an impossible hope to give people. What I have found as a helpful frame is, which suicide shall we say was okay? And if none are okay, then we have to keep striving for zero. It doesn't mean blaming people. It doesn't mean not supporting people. It doesn't mean not having empathy or understanding. It's a goal for us to keep marching towards the best outcome possible.
I think we have a couple of questions online. The first question is, what mental health survey are you referring to?
This was built by USC. It's called My Mental Health. It's developed by USC itself, so it's not a nationally available survey.
Thank you. The second one is, thank you for your presentation. Do you have a document that you would be willing to share regarding your incident review process?
I am happy to. The process that we use is root cause analysis, and also called Ishikawa diagram or fishbone analysis. It is very well described. There's lots of published articles on it in textbooks. We just use that same framework.
Thank you. One more. Thank you, Dr. Batra. Thank you for sharing today. There's not only a problem of stigma about mental health for college students, but universities also have policies that make the choice difficult for students to decide between getting crucial care, for example, taking medical leave and maintaining their academic and financial aid status. There was recently a New York Times article on this topic of students being forced to withdraw and reapply, which exacerbated their crisis and delayed care. Has there been any integration of these considerations in implementing care for students and building trust in USC's resources?
I literally shared that New York Times article with the leadership this morning. It's such a vexing problem. I guess it would take a lot of time to give context for that. It's basically when students are struggling so much that the stress of school is so tough that helping students reduce that stress to take a health leave of absence, but then it also comes with other complications like potentially losing scholarship and, like their purpose, which is one thing that keeps us all going, is having a purpose in life. So it is such a double-edged sword. We are making those decisions with students on a case-by-case basis. I cannot think of a one-size-fits-all approach for that at all. And we do that with students. So we try and minimize the impact on their lives, and just keep that. The first thing is for them to stay alive, right? That's the most important thing. And then helping them with all the other problems. So we're doing this literally case by case.
One more question. What services do students receive post-graduation? Are they cut off?
So graduating students, we connect them with care. So we start planning. So for example, the student insurance that covers them for care while they're at USC runs through mid-August of after graduation. So we have about 3 months to continue to see them, and our case management will help them build connections in their home communities. So that's a lot of time investment that we do. But they wouldn't be able to stay at the same clinic at USC. But we do make every effort to connect them.
Okay, we have time for one more question. Right here. If it's a quick one, maybe we'll do 2. We'll see.
Hi, Dr. Batra. My name is Lorena, and as far as the topic on care for the caregivers, I think we should advocate more for the staff, the nurses. Last year, I lost my husband from fentanyl overdose, and I was fortunate enough that Dr. Jonathan Wong advocated for me. Otherwise, I would not have made it. I think it should be part of the daily huddle whenever we go to work. Management should really look into their employees.
Yeah. I'm so sorry for your loss, and I couldn't agree more. It's the impact on all of us as family and as caregivers is tremendous.
Okay, one more.
Good morning. My name is James Wilmot with VPAN, Veterans for Access Network. Upon the freshman class, what's your percentage of veterans that you're treating?
I'm afraid I don't know the answer to that right off the top of my head, but I'm happy to look that up.
Okay. Thank you. Do you have a quick one? Okay.
Well, I don't know if it's quick, but I'm a counselor at Cal State LA, and I want to ask about access to care. We have very different demographics too. Good news on our side is I think we have a much lower rate of suicide attempts, successful suicides. Very different than at USC. I just know from talking to my colleagues there. But we also have students that are Black and brown, a lot of immigrant students, a lot of students that are undocumented. And we don't have student health insurance. They have to get Medi-Cal. And then we also don't have a psychiatrist on staff right now. So I look at your rich program that you have, and I know I'm probably not the only one from an agency that serves this population of people. The Medi-Cal system is very broken. It's really, we fight like heck to get them. We do have a resource person that hooks them up with psychiatrists, but makes it so much more difficult. And when you're trying to get a student that's fragile, is suffering, whether it's with suicidal ideation or severe symptoms, you can't just walk them down the hall to a psychiatrist. It just makes it that much more difficult. And I think we have a big problem. And my suspicion is that in terms of the successful suicidal and the high-risk people that are out there in this country in general, not just at USC, is that access to care is a big problem.
Undoubtedly.
And I don't know how, I mean, I'm asking to solve it.
You are absolutely right. Despite all of these, we could double our program and still not meet the need. So I appreciate that we do have a lot of resources at USC, and I must thank USC for putting in the resources. Not all universities do, right? So we appreciate that the university has prioritized this. They support the programs that are not revenue neutral. They invest in these programs, and still it's not enough. And I can totally appreciate where those resources aren't even available, how much more complicated it is. Thank you all.